if I don't talk very loud. Pleased to meet you all. I'm Matt Eves. I'm a population health management specialist working in Derbyshire Community Health Services. Just here today to sort of take on a bit of a journey through our approach so far on scaling healthcare equity analysis of access and experience. Sort of a work in progress. It's a bit iterative, but hopefully you'll see the past sort of 12 to 16 months of work in the next 20 minutes. Quick overview there. I'll give you a bit of context. I'll then run you through a summary of the work to date, where we think this might fit, share some outputs. I'll talk you through some outputs, and then some requirements. And when I say rough ROI, incredibly rough, bit finger in the air, but just to give you an idea in terms of where this might fit in terms of comparing it with other methods instead of these. So some context. I don't think this will be news to anybody in this room, but health inequalities can relate to these three things highlighted there on the screen: access, experiences or outcomes, and tackling these is a key purpose of ICSs. And the work I'm going to share with you today focuses on the first two. Quick summary of the work then. So now I'm risking the 4-click scenario. So our informatics team developed a BI dashboard initially, and in the design of this, we kept it really simple. We had literally 4 quadrants looking at, in this one, waiting times by a couple of different things. One was a really high level of ethnicity, and that was because of a low numbers issue and because of the population of Derbyshire heavily skews our ethnic breakdown to white British. So that top left chart that you can see there is actually looking at the ratio of waiting times between white British patients and everybody with an ethnicity other than white British, which is in no way to suggest a homogenous group, but it is very much a low numbers problem in our local demography, relatively speaking. So the other charts here visualise sort of average weight by service line, average weight by IMD. I think there might be a typo there, and also average weight again by compared to volume of weights. And we used this and we identified an outlier and we did some exploratory data analysis on that outlier service. But none of that work could scale. So it was sort of, okay, well, that was great, but we've got 40 other services, and how do we make this, how can we take from that and apply it to the other 40? Which is where this sort of work started. So just taking a little journey. So I've just talked you through that dashboard and we used that to identify an outlier. Did that sort of deep dive work, shared some recommendations with the service, and then I started to commence a couple of sort of various tools which together are so far now being used as our approach. So a geographic modelling app looking at physical access to sites, so how much of our local area that we operate within can access at least one location of a service within a given amount of time by a given means of travel. And then in parallel, I was asked to do some work to look at do patients with an LD or A status, that's learning disability and or autism flag, do they wait longer than patients without? So I did some one-off work, and again, that one-off work didn't scale. So looked at that and subsequently to doing that, I started to develop something which would essentially replicate online odds ratio and relative risk functionality. Did a bit of engagement, iterated it again to incorporate some statistical tests, did a bit of engagement, and then a third iteration. So now I was looking at how could I use this then to, rather than to take in a data set and either run it for an entire organisation or run it for a single service or run it incrementally for every service within an organisation. And then started to look at a natural language processing app to start to look at experience. And all of this is, you can see the time frame because it's ad hoc, it's like in between many other commitments. This then continued into this year, so then started to develop odds ratio functionality for the experience side of things, which a bit of stakeholder engagement, and then started to look at, okay, well, what other outputs can we incorporate in terms of text from patients and feedback. Use this to undertake our trust level analysis of access and experience a couple of months ago. And I've then used that to identify a service and particular demographic groups that we could prioritise focusing on initially. And this is where we're now at. So now we're sort of in a planning stage to undertake some patient engagement with the identified service and identified groups as a result of the previous tools. So in terms of where this is intended to fit, I'm not going to read through all of those, but there's a plethora of different improvement methodologies, which I think could be boiled down to essentially audit if you're on your first pass through the loop, or re-audit if you're on your subsequent pass through the loop, and identify groups experiencing inequity in this context. Then undertake some targeted engagement with the groups you've identified. Create and prioritise solutions to identify the solution or solutions that you can implement that solution, and then re-audit. Now, I'm sure that there are people in this room that have experienced this sort of scenario and online, where you might have not done that part of the quadrant, if you see what I mean, and gone straight from identify problem, have solution to problem, implement solution, and it may have been a great solution, or it may not have done had the desired effect. And so really that's where these were coming in. So this is where the intention here is that if we could have these sorts of scalable tools that could do a few things at scale. So in no way do they replicate everything in that original exploratory data analysis piece, but they're not intended to. They're intended to do some things at scale. So weighting list equity, natural language processing of experience data, and looking at geographical access, and apply those in both the audit stage. But then one of the reasons why, or the suspicions I guess I had why sometimes that second stage may not happen, is capacity, maybe, because it can be quite a time-intensive piece maybe. So that's why, in addition, the NLP piece, as hopefully I'll talk through in a second, could apply to expediting that thematic analysis stage. So I'm just going to run you through a few of these different outputs. So initially here, you have I'm just checking if this is running. Here we go. So this is for the geographical access resource. So you enter an API key, which is available from an open root service. It's a fantastic open source resource, and you select your means of travel, enter some information on the locations. And it's really got three stages. It's literally geocode the postcodes, develop some isochrones from the geocoded points, and then identify what is the area of the reference geography that can access within the given time frame. In this example, 20 minutes by car. So these are all many different test data points of locations, and the green shape, it's not so green on there, is the isochrone of everywhere that could access within a time frame. But it could also be used to model either increases or decreases in size. So this is an example here where it's going to run 3 scenarios of reducing the number of access points. So this time to 3 scenarios with 4 points. You could also run it for every single possible combination of size n. So you could say, okay, well, I started with 20, but I'm now going to reduce to 15. Let's run every possible combination of 15. Same 1, 2, 3 process. So geocode the points, get the isochrones, get the area that can access within the given time frame. I've sped this up because running 1,001 combinations takes a little while, so I thought rather than everyone sit here for 20 minutes of buffering. But what you get here is 3 outputs, so you then get all of those 3 scenarios. Now the area in red is now the area that could have previously accessed, but now wouldn't be able to access within 20 minutes by car, because those clinics have now been varied, so that's varying for each of those scenarios. And these 2 tables here on the left is every possible scenario of the 1,001 in this example, the percentage of the reference geography, in this case Derby and Derbyshire, that could access within 20 minutes by car. And on the right is the percentage of the core 20 LSOAs only, so the IMD quintile 1. And then this XY scatter is just showing you those 2 things. So in the top right, you'd be able to have like optimum access of your remaining locations from both of those points, or you could optimize for one or the other. So I'm just going to show you the other examples. So that's the as is. It's quite hard to see there, I'm afraid, unfortunately, but what that's telling you is the percentage of that outer perimeter shape, so the reference population, reference geography that is covered by the green shape. For both the whole and the LSOAs of the core 20 within it. This is if you were increasing sites, so the darker green is the areas that could now access within 20 minutes that previously couldn't, and the darker red, as you saw before, is could previously access but now couldn't. So now I'm going to run you through this waiting list one. So this is a similar look and feel, but this is now looking at, again, there's a little bit of setup with these, so load up the file, select the columns to try and keep it generalizable. So I've pre-prepared this for the interest of time here, but that will show you there like the missing data count by field. This is where you could run this for one service or all services. In this case, I'm running it for all, and it shows you the service names there. This is test data, so it's just service A through to service J or something. Setting up the odds ratio, so this is where you select what is the measure that I'm interested in. So here I'm replicating that idea of, are people with a learning disability and or autism flag waiting longer than people without that diagnosis in the record? And then the waiting less than the target. So this is a derived variable in the background because as part of the setup, you set your threshold. So I set in this 18 weeks. That then creates a binary variable of true or false, depending on whether or not that waiting time is less than or equal to that 18-week threshold. And then run it, and then you get your results. So here is just like the odds ratio of the source data saying that, yes, it's significant, and then the subset of those services says, yeah, it could run for 6 of the 19, and it was significant for one of those, but you can also steal the results of the others. Then it gives you the relative risk output as well. But then the Kaplan-Meier survival curve is undertaken. Because it's test data, you can see there's a bit of an anomaly there in the long tail, so apologies for that. But this was added because the odds ratio output is influenced, obviously, by the threshold that you set. So I thought, well, actually, this might give us a bit more assurance in terms of the results that this might provide. And then finally, you could analyse the weights here using this resource by any demographic that you want. So here I'm analysing it by gender. There are 3 labels in the gender column here. Might be tricky to see, so I'll just describe it. There's M, I, and F. The I has 2 fields, so in running this, it's highlighted there to say, I'll run the test, but there's a warning. You should have counts higher than 5. So you can simply go back and deselect the label. It'll then subset those records out of the data set, press go, rerun it. And now it will run a manual EU test. It's also trying to detect if it's normally distributed, and if it isn't, transforming it. And if that fails, it then runs the relevant non-parametric test. But you don't need to worry about that because you literally just load up the data and then have a look at the output so much. That was the intention anyway, to try and make it as time limited as possible. And then any significant findings are rendered here. So it just sort of indicates, if you selected multiple columns, you would get multiple in this table here. In this case, it was just gender, so it says for these 4 services, these were significant. Moving on to feedback. So this is a bit of a learning curve for me as this was getting put together. So again, similar look and feel. All of these are built with the Streamlit Python library. I don't know if anyone's familiar with it. I'd recommend it. It's phenomenally easy to get going with. And what I'm doing here in the setup is just telling the sort of app, if you like, that this is a label data set. So I'm telling it what are the labels that are good, what are the labels that are bad. But if it wasn't a label data set, it would run sentiment analysis in the background. And then you can, same sort of idea as before, select the demographic variables that you want to analyse your sentiment by, and then this gives you a little preview of all your selections, and press go. That's all like a setup page. I've tried to isolate the 2 in this. But then on the outputs page, it then automatically starts to populate then based on what you've just populated in your setup. So here we get the word cloud of positive, word cloud of negative. You get like the 10 most extreme positive or unusual or outlier positive comments and unusual or outlier negative comments. A topic modelling outputs here. So this is really where I was trying to go about a way of expediting that thematic analysis piece. So this is positive topics and terms, negative topics and terms, but also the original source data spliced down into those topics. So if you wanted to go and validate that, check that, do further thematic analysis, you can. And then an odds ratio of basically here it's being applied to the idea of what's the likelihood of giving positive feedback compared to the likelihood of not giving positive feedback in this group compared to every other group. So you get a breakdown here by demography, and it shows you in this example with test data. And then that one particular group was significant. And then all these cascade sort of windows are isolating the subset of source data for each individual unique demographic. So ethnicity, white ethnicity, black, and so on and so on. So you could see, okay, well, what's the particular sentiment and themes and topics coming out from every individual unique combination of demographic breakdown in the data set. And then finally, very similar is looking at survey analysis. So you might not have a labeled data set. You might have identified some groups that are experiencing variance, and then you might go and do some engagement with those groups. And then you've got the problem of how do I do that analysis piece quickly? So very much my aim with all of this was how do we do this thing quickly? And so What this is now is repurposing some of what you've seen before, but in the context of an unlabeled data set. So running a sentiment analysis, running topic modelling. You can run a brute force approach within this. So you could say, okay, give me the ideal parameters for this topic modelling approach. It does take quite a while. The brute force isn't the optimum approach. I need to figure out a better way of doing that. But you get these sorts of outputs here, which again shows you the key, like the top topics and terms for each of your topics you've selected. By default, it chooses 3 topics, but you can vary that in the parameters. So summary of requirements. Python, organizational support, particularly IT and IG. Some time to build, but obviously, these will be shared. One of them is already on GitHub, but the other 2 will be. And so you haven't got that lead-in time up front. And some really, really rough, I mean rough, there's no science gone into this very much at all in terms of these ROI figures. But just in case people are here as sort of consumers of information as opposed to the builders of these sorts of tools, I think it's quite important to stress that sort of rapidity that you can achieve with these sorts of methods. So I'm always staggered by how quick it can be once you've done the build, how quick it is to run and churn. So I just thought I'd put in some really rough indicative figures in case if there's people in the audience in that position. So thanks ever so much for having a listen and seeing our position on that journey. It is a bit iterative, it's where we are at the moment, but I'm really happy to take any questions.
That's brilliant, thanks Matt. Are there any sort of questions online we can take first, Lucy?
So I'm going to sort of group 2 together. There's a bit of a theme around the patient engagement, bit of a loop. So kind of so where the data's come from, which I think you said was friends and family test, but also how how it can handle the challenges of engaging with patient groups that historically don't engage with the NHS, so potentially underrepresented.
Yes, so to take your first question, so the data, everything I've showed you there is using test data, but when we've applied it is using friends and family data, and that is obviously only the people that have given feedback. So I think there's a lot of the interpretation from this has been with caveats of, this is based on the X% of people that have been been able to and subsequently had the agency to give that feedback. So it isn't. I'm not saying it's a representative sample, but it's the information we had available to go on at that point. So it's very much leveraging what we have, recognizing what we have isn't necessarily the ideal state. But it does then lead us to a point of the engagement, the patient engagement, which is our next step with this work. So we've used this to identify a service that is experiencing or that had either a higher groups experiencing variants that we're now undertaking that patient engagement journey with. So we're in the planning stages for that, but that's our next step. So it's sort of using these sorts of methods and tools to identify and prioritise to then do the engagement, but then using them again to sort of leverage the insight from that engagement as quickly as we can.
I've got another sort of cluster of questions. Sorry to butt in, Andy.
Go for it,
so there's a cluster of questions around who you intend to be working with to use the tools and how you're sort of communicating that with them.
Okay, internally, so I've used these tools with. So I've run the tools, if you see what I mean, but then I've communicated the outputs from them. So throughout all of the governance structures of our organisation, I think in April presented the output to our board, and have shared the outputs with the service leads that have been identified from the work. Externally, when one of the 3 is on GitHub, if anybody wants to iterate on that, develop that, review that, use that, that would be fantastic. And so I'm always happy to have a chat about expanding the use of these sorts of things.
Thank you. That's it for me.
Yeah, great. And really great to see on GitHub as well. These are the sort of tools which should be productionized and shared so that everyone can kind of benefit. Looks like a really useful tool. Are there any questions from the room then for Matt?
Hi,
Hi.
I'm Karen. I'm from Versus Arthritis. I was just really interested when you said you could do it kind of per service or organisationally. How much of what you're seeing is kind of the same thing over and over again between services and perhaps shared learning about, I really liked your little kind of circle of improvement, but at the same time, does every single service need to do that, or is there a bit of shared learning that you can kind of think about?
Yeah, I think it's a really good question. And I think it's exactly the sort of question we're sort of in the process of wrestling with, because I think there's something around not only the impact on a service undertaking the engagement, but also the groups that you're engaging with. So if you don't want to go and well, I don't know if you want to, but I imagine you don't want to over-engage because of the whole, you might have a decay in response rates and so on. So I think that might then lead thinking into, well, how do we do the engagement? Do we go out into communities? Is that the best approach for this particular group, for this particular service? So all of that is a question we're currently in the throes of wrestling with, but we have had conversations with our local Health Watch and with our local ICB colleagues and with our local patient experience team colleagues and local authority colleagues to try and get a picture of what are the engagement sort of opportunities or options available to us that we have established now, and then we can start to think, well, how do we use those? What's the best way we think we can use those for this service and this group, if you see what I mean? So that's our current approach as to where we're at with it. But yeah, absolutely, I think there is a challenge that if we did this service by service by service, there is a risk that A, have we got the capacity to do that, and B, are we over I don't think you can over-engage, but there's a risk that we seek the same, the answer is the same and the problem is the same. Do you see what I mean? So, and I don't want to presume it is, but I think there's a balance to be had with that approach, definitely. And I think there's probably going to be some further iterative learning as we go through that part of the loop first time and the second time and so on. So I haven't got a clear-cut answer for you just because it's where we are, but hopefully that gives you an indication of our thinking is to try and get a lay of the land, so to speak, and then set our course for the first time and then learn from that. Does that help? Great.
Any more online questions, Lucy? Or?
We just got one, which is, what are some of the potential biases and pitfalls to watch out for when developing such dashboards and tools?
Oh, yeah, that's a good question. Biases and pitfalls. So I think there is something, and I think a pitfall could be, so the approach I've tried to take with these is to build them in a way that I'm not presuming that a field is called a particular field name in a way that you can set which field name it is. But it still, I think, makes an assumption in there that there is a data quality query. So like if you have 3 labels, for example, in a string, in a text field, A, B, and C, whatever those labels represent, it's assuming that A is different to B and B is different to C. But if you have A and B that both mean the same thing and C is a separate thing, then that is something that is a probably source data quality query. And so that would probably need resolving before this, because this would otherwise try and detect the difference between A and everything else, B and everything else, C and everything else, and we'll have no concept of the fact that A and B are the same construct. So I think there are some pitfalls to be had. There is something, it doesn't remove the need to understand the data quality that's going in, but it does help surface some of those issues, because you can start to see, hopefully in there, that it brings you out a data quality overview, how much of this is missing. It doesn't tell you if what isn't missing is semantically correct. So there is something around how do you still need that? You still need to have that part of the process. Is that okay?
Great, thank you very much.
Okay, that's perfect. So unless there's any other questions from the floor, again, show your appreciation for Matt. Thank you very much for sharing your work.